Okay, so first of all, I would like to take the opportunity here to welcome everyone to this short tutorial slash lesson regarding APRV. I wanted to also at this time, before we begin, to extend a big thank you to everyone who took my online survey and test regarding APRV, and really it was just to get an idea, a knowledge base about kind of where we are as a department and our understanding of that mode of ventilation. As you may or may not know, we as a system are in the process, or as a system, we as a hospital rather, are in the process of developing a policy which we all might be able to use when it comes to this mode of ventilation. And in this way, I felt like to have a standardized way in which we approach this mode of ventilation, and not only that, but also to have a standardized way in our own understanding of it. So following this tutorial slash lesson, probably about a week after, I will be sending all you people an email again with some links to another survey and test, which I hope you'll take the time, the opportunity to sit down and take this small survey, take this small test, so that I can determine if this has helped you in any way, shape, form, or fashion. So, kind of gauging people's understanding, and I want to know if this was helpful or not. If you have any questions, anyone out there has any questions, please feel free to contact me in any way you see fit. My email or phone, of course, is always available. More than likely, you'll see me around the hospital at some point. So if you want to ask me any questions, I will always be available. Now, let's talk a little bit about APRV. So I wanted to really tell you basically, and even based upon those previous surveys, about more about why I wanted to do this. Why use this method? What is the purpose here? So the purpose in this presentation is really to, first of all, to make you more confident about the use of APRV. And then also to help you recognize some of the basic indications for the use of APRV. And in the end, yes, even to give you some practical knowledge for the application, for the management of a patient on APRV. So that's pretty straight. I feel like that's pretty straightforward in that, I wanted to make people more confident, more secure about this mode, give them some indications, give them some practical knowledge, some things like that. And that is a beginning of things that you can work with to use this mode. So first, what is APRV? Well, simply put, APRV is airway pressure release ventilation. So it is a mode of ventilation which allows for unsupported spontaneous breathing at any phase of the breathing cycle. Okay, so I don't want that to sound confusing. So how I had it told to me once, or instructed to me once, is that basically APRV is CPAP with intermittent release followed by reinflation, so that the patient is able to breathe on the top end at we'll call it the pressure, the high pressure, breathe at the lower end, the low pressure, their own spontaneous tidal volumes and breath. In the medical community, this is kind of what most people call open lung ventilation approach, because APRV now we understand what it is. APRV is being used to open the lung and to recruit alveoli. So it's called an open lung ventilation strategy. Now, some basic indications. Of course, one of the primary basic indications for this mode of ventilation is going to be a process known as ARDS. I feel like we should spend just a couple of seconds talking about ARDS, because ARDS is a medical acronym talking about acute respiratory distress syndrome. I want to talk more later about where it comes from and the mortality rates for it, but we can say that ARDS, according to our current understanding and to our current definition, results in an oxygenation deficit for our patients. So patients who develop acute respiratory distress syndrome will oftentimes go into a very hypoxemic state despite being on a very high FiO2, or despite sometimes being on a very high levels of PEEP. They just can't seem to oxygenate, so they get into an oxygenation deficit. On the slide here, you can see that this deficit can either be termed mild, moderate, or severe. And this comes basically from an ARDS task force that was designed to standardize the definition of ARDS and what it meant and the different types of signs that you see. So if we look on this slide, we're going to be talking about these different levels. Now, I want to make the small statement that PF ratio is the PaO2 to the FiO2 ratio. So this is the current criteria, which has been laid out for us by the ARDS task force. So if you have a mild hypoxemia, or if the deficit is mild, then the PF ratio, or the PaO2 over FiO2 ratio, will be between 200 and 300 millimeters of mercury with a PEEP of equal to or greater than 5 centimeters of water pressure. If it's moderate, the PF ratio is between 100 and 200 millimeters of mercury with a PEEP greater than or equal to 5 centimeters of water pressure. And of course, severe, the PF ratio is less than 100 millimeters of mercury with a PEEP of greater than or equal to 5 centimeters of water pressure. Now, I said that we would come back to the etiology or the source of ARDS, and that's the real trick about ARDS, is that in all the medical literature, ARDS does not just have one simple source, one simple etiology. The fact is that ARDS, acute respiratory distress syndrome, can have multiple etiologies or sources. Now, for our area, mostly what we have seen when it comes to patients that develop this process, so I'm just kind of going in our area, mostly what we have seen is the main etiology of ARDS in most of our patients ends up being trauma of some sort, in which the lungs have received some sort of insult or acute lung injury, which leads to inflammation, ventilation perfusion mismatching, and eventual ARDS. So when we talk about the lungs receiving some sort of trauma, that can either be, we think about the obvious ones like a gunshot, or being in an MVC, or something like that, some sort of blunt chest trauma that is applied, that insults the lungs, applied or insults the lungs. But you also think about some of these patients that have come in that have inhaled foreign substances or what have you, that have damaged or caused trauma to their lungs just by the fact of inhaling these foreign substances. Now, I will say this, that in the literature, in one of my sources, that 24% of patients that were admitted to the hospital without acute lung injury but received routine mechanical ventilation developed acute lung injury within 48 hours, with 80% of those patients progressing on to develop ARDS. So sometimes these patients have come in, they have nothing wrong with them, they were put on mechanical ventilation, they developed acute lung injury, which led to ARDS. Now, here's the thing with ARDS, is that, ARDS has a very high mortality rate, and it's been around for a very long time, and we get better and better every year about understanding how this process affects the lungs, but it can affect the lungs, affect the body in different ways. So the mortality rate is usually around 35 to 45%. Now, before we move on, most people ask, does APRV, does this mode of ventilation statistically reduce, and that's the key word, does it statistically reduce the mortality rate of patients who have ARDS? I did a lot of literature search and resources here, and the answer is no. However, I will add this, is that APRV has been shown to statistically affect the oxygenation status of patients if applied early. So again, even though APRV has not been shown to statistically reduce patient mortality, it has been shown in several studies to statistically affect, for the better, the oxygenation status of patients if applied early. Now, let's move on to some basic settings. There are multiple ways in which you might apply APRV to a patient. So, with the help of one of our local physicians and with the help of some of the therapists that are on a council who are also seeking to standardize a way in which we apply it, I will give you a set of basic settings that can be applied to a patient. However, I want to make this abundantly clear that that these settings are in no way a substitute for the good eye, for the clinical knowledge of a bedside respiratory therapist. With that said, I want to say to please monitor and observe your patients closely. First thing, let's talk about sedation. You can ventilate, yes, it is true, you can ventilate with APRV on a sedated patient, but it is in no way useful for that patient. Sedation must be turned off for the patient to benefit from this mode of ventilation. Remember, it allows for the patient to have unsupported spontaneous breathing. So there must be spontaneous respiration, spontaneous breaths. Now, let's talk about P-high or high pressure. Generally put, this setting is at the previous mean airway pressure. So when you're flipping over to this mode of ventilation, you're going to make note of a couple of things. What is the mean airway pressure for the conventional mode of ventilation that you're on? That usually equates back over to the P-high or the high pressure. Now, the T-high or time high, I'm going to give you a range that usually, a lot of the literature sources say can be set in. The T-high usually is set around 4.5 to 6 seconds. The low pressure, or P-low, is always set at 0. That is in order to optimize expiratory flow. And the T low, or the time low, ranges from 0.5 to 0.8 seconds. Now, before we move on to another slide, I want you to look at the small illustration on the right side of this slide here. This is the flow waveform. This involves T low. This is the crucial component of this mode of inhalation. So if you think of the expiratory flow rate waveform below the line, which is really the peak expiratory flow rate, if you think of it as numbering from 0 to 100, going from right to left, just as we see in the illustration, then you want the expiratory flow to terminate before it hits baseline. So you want that expiratory flow to terminate either at the 75% mark that you see there on the slide or at the 50% mark. That means that if you have the T low set at 0.8 seconds and you see the waveform terminate around 25% of peak expiratory flow, then you must adjust the T low. Which way do you adjust it? You adjust it to terminate quicker. So you would go lower, such as 0.7 seconds or 0.6 seconds. And I would suggest 0.1 second in increments so that you can determine where that flow waveform is going to terminate at. I'm going to talk more about this here in a minute, but the trick is not to allow it to terminate at the 25% mark or less, because that means alveolar de-recruitment. I know you may have questions. That's fine. No problem there. Because if you're anything like I am, then you need hands-on practice. So, contact me. Ask your questions. We can get a ventilator out. We can look at this, whatever, to help you with this process. But you don't want to lose all the alveoli you recruited. So what we're doing in basic effect is we are causing air trapping. We are causing a little bit of hypercapnia with this patient. So you want the flow to terminate, if you look on the illustration, around the 75% or the 50% mark. You don't want it to go to 25% or less, because that means you're losing the alveoli that you recruited. Now, lastly, of course, set your oxygen to 100%, because, really, more than likely you're already there, and, why not do that? Okay. Again, let's just touch back on these basic requirements. Sedation, right? So, sedation must be off. And, just like I said earlier, you're going to cause a little bit of permissive hypercapnia. It's okay for the CO2 to go up a little bit. That is fine. Also, think about your time flow waveform. You're going to have to really look at that and look at where that flow terminates. Another thing, don't be concerned with big tidal volumes. In fact, I tell people not to even look at the tidal volume, because what's going to happen is that as you recruit more alveoli, what you're really doing is that the tidal volume is going to equal total lung capacity here, because you're recruiting not just the part of the lung that deals with the tidal volume. You are recruiting the entire lung. So as the lung gets better, as you recruit more alveoli, guess what? Your tidal volumes may continuously go up over time as you recruit more alveoli. That is a good thing. That is what you want to do. Now, if your patient gets better, congratulations, you're ready to wean. So, weaning is a little bit different than what we're used to, and I've often heard it called by one of the physicians, by some of the therapists, as the drop and stretch method. Because once recruitment is optimized, then here you can start reducing the P high by 1 to 2 centimeters of water pressure and increasing the T high by 1 centimeter of water pressure for every drop in P high. So you kind of get in your head then, right, where what the drop and stretch means. So you're going to drop the P high and you're going to stretch the T high. You don't need to be in a hurry to do this, because oftentimes patients can be very comfortable on this mode of ventilation. So, do it every couple of hours. Don't put yourself back at the starting line. Don't de-recruit alveoli. Once this is done slowly, then take the opportunity to reduce your FiO2. Now, once your P high reaches 10 centimeters of water pressure, and your T high is somewhere probably around 12 to 15 seconds, and you're at 50% FiO2, why don't you just try changing over to CPAP of 10, pressure support of 10. There is no need to go back to a conventional mode of ventilation once you have begun weaning and gotten to that area or time on APRV, because you're basically on CPAP anyway. So why not just change to a CPAP and pressure support? No need to go back to conventional ventilation. And I cannot stress this enough, over and over. Please look at your patient. Don't get lost in the data. Monitor their work of breathing. Monitor their heart rate. Look at their blood pressure. Look at your patient. So, basically, there you have it. Those are some of the source materials that I used. And that's about it. Very simple. So I wanted to, again, extend a thank you to everyone who helped to participate in this project with me. I will be sending out a link to a survey and a test again regarding APRV. Please check your email and do these. These in no way reflect on you as a therapist. They only help me to determine where I need to go or what I need to do in order to help you. These links are truly anonymous. No one is tracked. I don't know what anybody answers here. I'm the only one who sees the data. So please take some time, do the survey and test, and I would like to thank everybody. Thank you.